Welcome everyone to our newest webinar, where we will be asking your remaining questions from our live webinar from Dundee with the amazing Tom Gilbertson. Tom is the Senior Clinical Lecturer at the University of Dundee and Honorary Consultant Neurologist at NHS Tayside. So Tom, thank you so much for coming back to answer the remaining questions. There were so many when we met, and I think without further ado, we should probably crack on.
Oh, thank you. No, it's a pleasure. Yeah.
So our first question is, will psilocybin studies be used in the coming years for use in dystonia?
So that's a very interesting question. To my knowledge, I don't think there's any current studies that are considering answering that question. The main role for psilocybin has been in depression research, and that's been a very controversial area because it's a psychotropic medication, so it's related to, it has in principle hallucinogenic properties. And it's been very difficult, I think, for the group who've done depression research into that particular drug to get approval. But I think it looks very promising for mood disorder in principle. Dystonia, though, the question is, what would be the rationale behind treating dystonia with that drug? And on the top of my head, I can't think of a mechanistic reason why you try that. So I think that's an unlikely avenue at the time being, unless something comes out from preclinical research suggests that it's going to be effective.
Okay, brilliant. Thank you so much. Our second question is, can sedative drugs for medical procedures, such as propofol, cause dystonia to flare?
So generally, when people are put to sleep under a general anaesthetic, their dystonia improves. So if you take cervical dystonia, for example, once somebody is anaesthetised, then their dystonia will be relieved by that, and that is similar to the process of physiological sleep. So sleep improves dystonia once patients can get to sleep. So it would be unusual for dystonia of a focal primary variety to be worsened in a direct sense by general anaesthetic in my experience. But as you know, this is a very unpredictable condition, and often there can be individual experiences whereby drugs or medication of any type, whether it's anaesthetic agents like propofol, can worsen symptoms. So it's not I don't think it's a recognised risk for patients who have focal dystonia not to have general anaesthesia, but I can't say that individual patients might not experience a worsening of their symptoms.
Okay, brilliant. And that makes sense, I suppose, when you're thinking about it in relation to how sleep can help dystonia.
Yeah, because essentially it's an induced, pharmacologically induced sleep state, the general anaesthetic. Yeah.
Brilliant, thank you. So our third question then, is there any research to indicate that other medications that affect dopamine, such as antiemetics or antidepressants, including sertraline, can make dystonia symptoms worse?
So in terms of so some antiemetics, so for example, drugs like metoclopramide in young people are traditionally quite strongly associated with either acute dystonic reactions, and I have seen patients who developed, if you like, a drug-induced form of dystonia with chronic use of dopamine blocking drugs like metoclopramide. So the answer to that question is that there is a relationship there. It's not that clear what the exact mechanism is of drug-induced forms of dystonia. The answer to the second question, I think, is about sertraline, which is an antidepressant. And I think as a general rule, there's no good evidence to say that sertraline worsens dystonia. If you dig deep enough, there's always going to be case reports, not dissimilar to the earlier question about propofol, of patients who've had adverse reaction to antidepressants, but there's no systematic study that shows that antidepressants worsen dystonia or cause dystonia. What I would say is that we know that as part of the non-motor syndrome of primary dystonia, anxiety, mood disorder are very much comorbidities in patients with primary forms of dystonia. So actually overall, in patients who have got significant affective mood disorder symptoms, they really need to be treated for that. So patients should be encouraged with focal dystonia to treat the inevitable, not the inevitable, but the common occurrence of mood and anxiety symptoms in this patient group. So I don't think patients with dystonia should necessarily be concerned overall about taking antidepressants like sertraline, and actually the benefit to their mood and secondary benefit to their movement disorder when their mood improves is certainly worth taking the standard antidepressants like sertraline.
Okay, brilliant. Thank you. While we're still on sort of medications, have you ever seen any evidence that Sativex, get the names right, can improve people's dystonia?
I personally haven't. Stativex is a cannabinoid mediated drug, and the its license currently is for spasticity. So people who have, so for example, multiple sclerosis benefit greatly, and we know from good evidence from trials that it's an effective treatment for spasticity. It has never really been tested in dystonia group of patients. It's actually a very interesting question whether it would be effective. There's some good evidence that the basal ganglia, which are one part of the network that goes wrong in focal dystonia, have receptors which express cannabinoid or have express cannabinoid receptors. So there is a rationale in some respects for thinking about using Stativex here, but there isn't currently sufficient evidence, or as far as I'm aware, any trials that are testing that question. But it's an interesting one, yeah.
Okay, fab. Can one be misdiagnosed with essential tremor instead of dystonia? And are there any overlaps between the two, is our next question.
Yeah, this is a very common and difficult area. And if you take a step back, the first problem that the doctors and clinicians have here is that we don't have any clever biomarker, if you like, so a blood test or a scan that can really distinguish between the two. So it's a clinical assessment, and we've got, I think, very robust clinical criteria that tries to distinguish between dystonia and essential tremor. But we see patients who have limb tremor, which is called tremor associated with dystonia, that looks identical to essential tremor, but the main difference is that they often have focal, for example, focal neck dystonia, and that really distinguishes between the two. The other problem, of course, is that in essential tremor patients, often after they've had essential tremor for a very long time, they can actually develop mild degree of dystonia. So there can be a very high misdiagnosis rate, and that it's a very challenging area. So it's not uncommon to meet patients who have been diagnosed with essential tremor who actually have got say cervical dystonia but tremor in their hands, and vice versa. So a really tricky area.
It is hard, isn't it, when there isn't a definitive blood test or test that you guys can do that can pinpoint one or the other.
Yeah, and sometimes somebody might present with symptoms at a certain point in time that look, for example, like essential tremor, and then a dystonic syndrome might emerge at a later time in the disease course. So the misdiagnosis is a product of the fact that the initial signs and symptoms weren't there at the initial presentation, and this is an evolving picture. So it is a really challenging area. Yeah.
Okay. And we're sticking with medications of assault. So why are patients not told before receiving botulinum toxin injections that this can lead to the muscles atrophying? Is this because of its low risk?
Yeah, So that's a really challenging area actually. So I don't know enough about evidence for muscle atrophy in dystonia. I think from the cosmetic literature, so literature that looks at using botulinum toxin for cosmetic reasons, there's good evidence that that potentially this does lead to much muscle atrophy. And in some respects, it would make a lot of sense that muscle atrophy will happen with repeated Botox injections into, say, or botulinum toxin injections into the neck. In my experience, it's generally pretty rare, and also it tends to happen after a very long period of time. So it's not something that you would expect to happen, within a matter of a few years. It'd often be after decades of treatment. And again, the challenge there is knowing whether, with chronic cervical dystonia, often you get hypertrophy, so too much muscle initially. And you might think that over a long period of time that hypertrophy then becomes atrophy because the muscle's so overactive, the dystonic neck becomes atrophied over time. So whether it's the toxin or the natural course of the disease, no one's really studied that in enough detail, I don't think, to really answer that question. And a difficult question to answer because of the potential need for a study that would go on for a very long period of time.
And just for people that don't know, can you quantify what muscle atrophy actually is?
Sorry, so muscle atrophy is where essentially the muscle fibers get smaller and smaller. So you lose muscle fibers and the muscle gets thinner over time. So typically at the onset, or when people present with cervical dystonia, initially they have overactivity and the muscles are a lot bigger. And you do see a small number of patients over a long period of time, the muscle becomes atrophic. Now, you could attribute that to repeated botulinum toxin injections, but equally, one of the questions would be, over a long period of time, and if you've had cervical dystonia for 40 or 50 years, does that lead progressively to, kind of almost a burnout of the muscle, because it's so overactive over many, many years that it actually goes from hypertrophic to atrophic? And I don't really know what the answer is to that question. And it could be related to botulinum toxin, but we don't know.
Okay, brilliant. Thank you. Our next question is, what is the efficacy of botulinum toxin injections for benign essential blepharospasm and oromandibular dystonia in terms of numbers of people with those symptoms?
What is the efficacy? So my own experience is that both forms generally respond in the majority of cases. Okay, so the majority of people with primary forms of blepharospasm do respond to botulinum toxin. I don't have a systematic number for you in terms of the non-response rate. Again, I think that's actually quite a difficult number to give you on the basis of the literature, but my own experience is that you see a group of patients who simply just don't respond to this. And I sometimes think that this is often a product of coexistence of another syndrome, which is eyelid opening apraxia, which can often coexist with blepharospasm. And eyelid opening apraxia often doesn't respond to botulinum toxin and is very, very difficult to treat. So I think this is a real unmet need actually for people with more severe blepharospasm. So the milder end of the spectrum, it's very treatable. The more severe end, and I think potentially with the eyelid opening apraxia patients who've got that as comorbidity, there's an unmet need in terms of better treatments. And this is very challenging actually. I think that there are small numbers of patients, not in the UK, who've had treatments like deep brain stimulation, but that's a very high risk treatment for sort of a focal form of dystonia affecting the eyes, and we don't know whether that's safe or effective for patients at all based upon a systematic evidence review. So yeah, I've got a handful of patients who are very functionally impaired from their blepharospasm, and it's a really very difficult thing to treat when it's severe and not responding to toxin. Yeah.
Okay. So our next question is, when botulinum toxin injections fail due to possible antibodies, what is your advice for future treatments down the line, and does that differ for different types of dystonia?
Yeah, I mean, generally, there are options to try and change the type of toxin. So the resistance to is often directed at one particular subtype of the botulinum toxin. So there is the option to change to a different subtype, but often that's only a partial solution to the problem. I think one of the things we try and do in my clinic is try and avoid resistance as much as possible by making sure that the dose is as minimum as possible. So trying to treat the lowest possible effective dose, and then try and treat with the largest interval between doses. Okay, so prevention of resistance is quite an important thing, I think, which has become more and more recognized recently. Ultimately, the patients who we've had who've become resistant, if their disability is significant enough, then medication resistance would obviously be an indication for surgical treatments like DBS. But yeah, I think the emphasis is on trying to reduce the likelihood of resistance over the lifetime of the patient's treatment.
Okay, brilliant. Thank you. We're moving on to diets now. Is there any evidence that a gluten-free diet helps people with dystonia?
Um, the short answer is no. I mean, I think it's very challenging, because when we think about celiac disease, it can cause a lot of different neurological manifestations. Dystonia, actually, I'm not aware that it's a common manifestation of celiac, but obviously there can be quite a big difference between having celiac disease and being gluten insensitive. There can be a bit of a spectrum there. And the challenge for patients with dystonia is that if we need to answer that question, okay, it's a boring sort of theme to a lot of my responses, but to answer that question in any meaningful way, then you actually need a very expensive and difficult study to look at the effect of gluten-free diet on the symptoms of dystonia, and that is going to be very difficult to design, appropriately power, so to have enough patients, and to fund. Actually, it's a very, very difficult question. So for patients with dystonia who have got gluten sensitivity, the answer is that no one can really tell them either way as to whether the gluten sensitivity in any way worsens their dystonia. And I don't think we will. I think it's unlikely we'll ever be able to really answer that question. But ultimately, if on an individual level that you've noticed a relationship between your dystonia symptoms worsening in the context of gluten, then it's pretty reasonable to try and avoid it. Whether there's a true relationship between the two, no one will be able to tell you.
Okay, brilliant. A separate question is, does smoking make dystonia worse? Have you heard anything about that?
So so there was some quite interesting stuff done, research done kind of, I think 10-20 years ago, which thought that smoking was potentially even protective against dystonia, but this wasn't. This particular group of Italian neurologists who identified this, and we're looking actually at caffeine as well, did a follow-up study, and actually they couldn't reproduce that relationship. So yeah, it's interesting that, because obviously nicotine receptors again are important actually in the way that dopamine is released. So there may be a rationale for a relationship between smoking or at least nicotine, or at least another chemical called acetylcholine, which is important for dopamine interactions in that bit of the brain. But I'm digressing a little bit, but the point I'm making is that no, that I don't think there is any there isn't.
I liked the answer though.
No, I know. No, I got carried away with thinking about neurotransmitters in the brain. There it wasn't really the point of the question, but no, I don't think smoking worsens or protects against dystonia.
And obviously, we do have to say, comes with its absolute own risk.
Absolutely, so, smoking's just generally bad for your health.
Yeah. Okay, so then our last couple of questions is, what part does genetics play with dystonia?
Yeah, so this is a good question because it really depends on age, and it's quite a complex question as well. So in childhood onset, often generalized forms of dystonia, there are often very strong genetic components to that. So if you and there's often a strong family history. So taking the condition like DYT1 dystonia, then that's clearly a strong genetic component to the manifestation of the dystonia. In adults who present with focal primary forms of dystonia, it's much harder to identify a gene. Okay, one study looked at this and studied around 1,000 patients with adult onset dystonia, and they looked at genes that have been identified with in families who had a very familial form of focal dystonia. So for example, that might have been a family with a form of cervical dystonia that had strong inheritability, and they had a gene that was associated in that family with developing cervical dystonia. And if you looked at those genes in people who are coming to your clinic, those 1,000 patients, actually less than 1% of those patients had one of those genes, that half a dozen genes that they tested. So in all likelihood, it's possible that there are genetic vulnerability factors that might be unique to people with adult onset dystonia without being, let's say, causal, and perhaps not having a strong genetic heritability factor. Okay, so it might be much more of an interaction between environment and multiple different genes in older patients with manifesting primary forms of focal dystonia, whereas in the younger children who manifest with generalized forms of dystonia, the contribution to genetic factors are much higher. So I think there's probably a spectrum in terms of the genetic contribution. It's not a kind of black or white situation. I think genes are very important in young onset and are probably less important in older onset, but potentially are important in late onset dystonia. But identifying those genes is very difficult in sort of people who develop what's called sporadic cases, so where these just come out of the blue without any familial history of focal or young onset dystonia. So it's a really good question, and I think a lot of people who've got a lot more expertise than I have in neurogenetics are trying to understand that in a lot more detail.
Okay, brilliant, thank you. And so our last question is, when Parkinson's is involved as well as dystonia, can there be a genetic link there?
Yeah, so generally when we see patients with dystonia in Parkinson's disease, it can fall into two kind of general categories. So young patients who develop Parkinson's disease, so these are people under the age of 50 generally, often have dystonia as part of their Parkinson's syndrome. So Parkinson's is characterized by slowness and stiffness of movement, but they can get dystonic posturing, often of their feet. That's a very common thing to see in a young onset Parkinson's patient. You can get dystonia in older patients with Parkinson's disease, so dystonia as a symptom, if you like, in the context of their medication. So often they can wear off medication and develop dystonia in a limb. So dystonia is if you like, is a symptom in Parkinson's disease rather than necessarily a primary syndrome, and it can manifest quite differently depending upon the age of onset of the Parkinson's disease.
Okay, that's really interesting. I'm sure when we do future that there will future webinars that there will be more questions on that kind of thing. So I think it's something that we get asked quite a lot. Tom, thank you so much. That's the end of our remaining questions. Thank you so much for giving up your time once again to answer them. It's massively helpful, and we know that our community absolutely relishes getting the chance to hear from you and your esteemed colleagues. So
yeah, great. No, it's been a pleasure. Thank you, Dana, for inviting me.
Always welcome. I'm sure we'll do another.
All right, take care.
You too, Tom. Thank you so much.
Okay.